And why this is okay. So why? So we have to understand what is health disparity first. Okay. So once we understand that, then how can we use biomarker to reduce health disparity? So this picture is really nice here. Okay. So look at these people here and look at these people here. Okay. So these people have access to advanced access and facility. So they can get the screening done. They are presumably pretty either powerful people or important people or rich people who have access to all sorts of things. And they are living in an environment where they have access to all of these things. Because you could be living in an environment which do not even have these facilities. If you are living in a rural village, they are not going to have all these facilities, right? So they appeared more educated and more, affluent here, and these are the people, they have limited access. That is health disparity. Okay, so it is not what we were saying again, that these people have aggressive disease. That is also health disparity, but this is also health disparity, unequal access to health care, health disparity. Okay, why these people have access, why these people do not have access, that is health disparity also. Okay, so this is precision medicine divide, but this is not the only thing. That is the important part. So usually underserved population often face barriers to accessing precision medicine. This sentence is very loaded. So what is precision medicine? That if someone has a disease, you give exactly the right drug to the patient. Okay, that is precision medicine. But if the poor patient does not even have access to the actual screening process to figure out what is going on, I will tell you case studies, and these case studies are very important with respect to precision medicine health disparity, because people don't know, they don't have enough money to get the screening. So somebody had HER2 positive cancer. This is a true story. So they did not have access to screen HER2, which will probably take one day, because you can do a PCR for HER2, but they did not. So what they were treated with? Chemotherapy. And the person died because, oh, this person has cancer, give chemotherapy. But a rich person comes in, they do the screening, they give HER2, that person survives. Right? That is health disparity. Okay? So I will tell you many things there. Okay? And all of these things are very important. Somehow there is a disconnection between the computer and this one. It shows something else here and something else here. So, so look at this picture here. So these guys, they have tailored therapies, real access to everything. And these are the guys, limited access. They are living in poor neighborhood with less access to stuff. So they don't get access to health service, right? So there are four things we will discuss here. Okay, precision medicine, you know already, but just a few sentences. This is the main thing, precision medicine disparities, and then how we can identify actionable biomarkers. Actionable words is very commonly used these days. Like if you find a good target, you call actionable target. Like if you take an action, it's going to show a result. That's what it means simply. Okay, eliminating precision medicine disparity. Then we combine the two things. We combine these two to eliminate precision medicine disparities by identifying actionable biomarkers. That is the other lecture of today, the last lecture of today. So precision medicine you already know so very nicely by now, right? And this is actually, precision medicine depends on a lot of factors, even where you live, in deciding that. Okay, the person's tumor genome and our own genome. So here is the thing, suppose there are 10 people with 10 and they have identical disease, identical grading, identical everything. and you give them the same therapy, this person will respond differently than this, than this, than this, than this, than this, because their genetics is different. And because their genetics is different, they will respond differently. So you have to look at the genetic also. The tumor genetic is different from the inherent genetic that we got from our parents. So we have to look at many factors before we come to precision medicine. As you will know more and more about stuff, you will understand this figure better. Okay, so we have to look at the immune thing, we have to look at the environmental exposures. Suppose somebody is living, so this is a true story, as I was telling you, near Michigan, in US, Michigan is a state close next to us. I'm in Indiana, Michigan is the next state. So there was a lot of contamination, and people who were living in that area, they were getting cancer. But these were, simple people. They had no idea that the water was so contaminated, and that's why they were getting cancer. And somebody figured it out. So somebody fought a case for these patients. So obviously the people who were creating all this dirty water, they fought it, and there was a big fight. And then finally the lawyer who was fighting for that, right? That lawyer won the case, and these people were paid billions and millions of dollars. Okay, they still got cancer, but at least they were paid, right? So there is a very famous movie based on this story. Okay, so what I'm saying is that today we will also talk about the environment, how much environment is controlling our diseases. Okay, so that is why lifestyle and environmental exposure, socio-economic status. You are rich, you have access to everything. Sometimes people are rich, but they're living in a place where they don't even have any knowledge about what to do or what not to do. So all of these things add up. Okay, so everything has to be considered to have the precise medication. So what are precision medicine disparities? Okay, so disparity in precision medicine means that not all patients have equal opportunity. This is different from what we are discussing here. So look at this sentence. Not all patients have equal opportunity to benefit, not receive, to benefit from advances in personalized medicine. If you replace this benefit word from receiving, then it is just a simple thing of rich versus poor. Somebody can receive it, somebody cannot afford it. It is not that. It is saying benefit. So benefit is a larger umbrella. Okay, even if these people can receive it, right, they may not benefit from it. Why? Let's look at that part here. So increasing diversity in research. So what happens? This will not make sense till we go to the next page. So disparity in precision medicine refers to unequal access. So rich people have access to it, poor people do not have access to it. That's one part. But this is very representation. What is representation? When they do clinical trial, right, in a country where, let's say, 50% people are white, and then, I don't know, I'm just making up the numbers, 20% people are black, 20% people are brown skin like Asians, and then 10% people are Alaskan, Hawaiian, not Hawaiian, Native Americans. So very different people, right, genetics wise, right? So when they do clinical trial, white are 50%, these people are 20%, 20% Asians, 10% others, right? But when they do clinical trial, 90% people are white, right? So the black people, Asian people, they are not represented in clinical trials, correct? So if you think even in precision medicine that Caucasian people, white people will have different kind of things than Asian, then like, Chinese people, they have alcohol dehydrogenase deficiency, but we are Asians too, but we don't, right? So different people have, different races have different kind of things. So if clinical trials, if our whole knowledge about cancer is only coming out from Caucasian people, if you use that criteria to some other thing, it may not work. So even these people are not taken equally in clinical trials. You don't have enough people of other ethnicities in clinical trial. That is also health disparity. So that is the meaning of unequal representation in clinical trials, right? I will tell you case studies about that. Okay, benefit that different groups of people experience in the development and delivery of precision medicine. So that is why even if Asians are rich, they are not going to get the right disease because they don't even know what is the right disease for an Asian person having this kind of cancer. Okay, so precision medicine, which aims to be perfect for one person, how it can be perfect for that one person, because you don't even have enough knowledge about that ethnicity here, right? That is health disparity. Okay, so disparity exists between limited tested and minority and underserved groups, underrepresentation in clinical trials, cost and access barrier to molecular diagnostic. All of these things contribute to health disparity. So these patients miss opportunity for life-saving targeted therapy. We have it, we just don't know what to give to these people. Okay, so that is why, see the survival rate, you can see here. Same disease, same thing, survival rates are different because of health disparity. Okay. So let's look at all of these factors, the key aspects. So obviously I did not know before I put this presentation together, I did not understand myself the extent of health disparity. All I understood before this presentation was that, few people get more aggressive cancer than other ethnicity, and that was my understanding of health disparity. Okay, so genomic underrepresentation. Most genomic and biomarker studies are heavily biased towards population of European ancestry, basically Caucasian people, right? Underrepresented groups include African, Hispanic, Latino, indigenous person. Indigenous person like Native Americans, people who are basically really are in minority. Okay, Asian subpopulations are less included, which limits the applicability of finding. So biomarker-based tests and drug responses may be less accurate for underrepresented populations such as these guys here. So lack of diversity in research creates disparity in who benefits from precision medicine. If a Caucasian gets, we can more accurately diagnose that disease, right? I will show you the case studies where Asians were given the wrong drug because they didn't have enough information. They were non-smokers and they were given these things. Access to technology and care. This is good. Rich guy has access to the health care. Poor guys cannot access. It is there, but they cannot access it, right? So rural areas, low-income patients and underserved communities often face barriers. Cost of sequencing, limited insurance coverage, fragmented healthcare system can prevent access to proper health care. Okay? Biological misrepresentation. Biomarkers validated in one population may not perform equally in others. So something which is validated in Caucasians may not work for African Americans, may not work for Asians, and vice versa. Okay? So this can lead to inaccurate diagnosis, risk assessment, treatment selection, everything. Then people who do not have access to these things, they are not even, sometimes, suppose they live in rural areas, right? So I live in Indiana, and Indiana is a vast majority of it is farmland, but it also has two biggest universities there. So a huge population is highly educated because students are educated and faculty are educated. But the rural Indiana, people are not educated. They are not even high schoolers, right? So they don't know, they don't understand healthcare or anything like that. So, when COVID came, they had mistrust in vaccine. They thought vaccine is something which is supposed to be very bad. It does bad things to your body. So they were resisting vaccine with all their power, okay? So that is what it means, mistrust in healthcare and research among historically marginalized people. Vaccine can, once in a while, can have side effect, but it has also saved life. This is my view. It is the view of many other people, but then other people have other views too. So the point here is that if you can educate people, then they can make their own decisions. But if they are not even educated, then how can they make the right decisions? That's the point here. Okay, so they don't have health literacy, communication barrier. Then comes the environment. This is very important. Okay, so this picture tells you about the health, environment. Okay, so here there is huge population like New Delhi. Okay, huge not population, pollution. Okay, huge pollution, right? Vector-borne diseases. Vector-borne diseases are those diseases which are, spread by mosquitoes and fleas and all these things, right? Like malaria, dengue fever, right? These are all vector-borne diseases. Racial disparities, okay? Health coverage, bad or good, okay? Disaster areas, right? Now, disaster areas is like that Michigan, the whole water was contaminated. Do you know what are food deserts? I did not know, I had to look it up. Food deserts are those places where you do not have access to healthy food. So the proper grocery stores are not there, healthy foods are not there. Okay, so people are eating really the wrong kind of food, and there are those areas where you don't even have access to healthy food. And then there are those areas where you never see trees or anything. You are living in a very polluted, no green areas, right? So all these things are bad for us in the long run. So that is exposome. Our health is affected obviously by the environment. Keep in mind, most of the famous diseases or the bad diseases like cancer, Alzheimer's, Parkinson, only 5% is genetic. 95% is the environment. Okay, so environment plays a very important role. Okay, so factors associated: social stressor, discrimination, poverty, violence, air pollution, lead, noise, occupational hazard, green space, absence of green space or presence of green space. Like IIT Indore, so much green, good for us. Living in I don't know where, but no green space is really bad. Concrete jungle, bad. Okay. Healthcare access, personal care products, diet, exercise, substance abuse. Usually, there are pockets in Indiana, there are villages in Indiana where things are very, very rural. They don't have too many people like us go there, right? So they are very closed communities, and I have met people from there because some of the people still come out and study and go for higher education, and they said that 90% people in this area in my village are drug addict. So if you go around, people are just completely under the influence of drug. And this is true everywhere in the world. There are always these pockets where more and more people are abusing, so they have substance abuse problem. Okay, so these, obviously the environment affects the epigenome, it affects the whole physiology of human this thing. Okay, so let's talk about exosome. So nobody who manages this class is here, right? Nobody except us. So we can keep going. Hopefully they'll remember us to remind us when to stop. Okay, so all the people who are controlling are out of the room. So it's our show. So we keep on going till they stop us. Okay, exposome. Okay, so this is the environment thing. Okay, so the person's physical, cultural, social environment plays critical role in their health. If you're a happy person, if you're in a happy place, your body is happy, your stress is low. If you're in a stressful situation, your environment is stressful, it will affect your body tremendously. Okay, so environment, home environment, huge importance. Education, employment, eating activities, drugs, everything, tendency of suicide, depression, all of these things, they are not just an attempt to document the story of a person's life, but to truly understand everything that embodies their reason that might have contributed to their disease. People who are angry all the time, real angry, they tend to have more liver cancer. Okay, anger is pretty bad because it really changes your physiology. and that contributes to cancer. Too much hatred towards things also leads to cancer. So what these emotions are creating real changes in our body that is fostering the growth of cancer. Okay, so so scientists lack reliable ways to measure precisely how non-genetic factors can help health and must develop ways to measure the effect of the social, physical, and cultural environment. I will give you some cases here. Okay, so one of the best cases that there is a very famous person at Harvard. He's of African American background. So people who live in South Chicago. So South, Chicago, you have all heard. So usually on the southern part of South Chicago, people who live are relatively financially less abundant people. They are of African American origins. They don't have, they are not very educated, and there is a huge crime rate, right? And they also have very high blood pressure. So for the longest time, people used to think, oh, they have originated from Africa, and this high blood pressure or hypertension and all these things are in their genetics for the longest period of time. But if you go back to Africa from where they came, those people do not have health problems at all. They don't have hypertension. So why these descendants have hypertension, right? Because they are marginalized. They don't have access to education that much. They don't even know much about education. They are living next to highways, industrial waste, pollution, because those are cheaper areas, right? They are not green areas. So these factors are the one which are giving to hypertension. But up until now, we were saying, well, they got it from their own parents, right? So that is not true. It is the environment which has given that. They did not inherit it from their parents, right? So that is exposome, your own world in which you live, your friends, your family, your environment, your social life, your professional life, that contributes to your well-being. Okay, so where you live, work, play, that's what is. So genome obviously plays a role, genetics plays a role. The complete set, genome is complete set of individual DNAs, which is the biological blueprint. If someone is BRCA1, BRCA2 deficient like Angelina Jolie, definitely more prone to developing cancer. So their genetics is playing a role. Okay, sickle cell anemia, genetics is playing a role. But exposome is totality of environmental exposure, physical, chemical, biological, social, lively. This determines how genes are expressed and how disease risk. So suppose you are smoking a lot or someone is smoking a lot, right? They can change their epigenetics so that the wrong things are expressed, good things are not expressed. Epigenetics plays a very important role because it can suppress good genes, it can activate bad genes. Okay. So air pollution, increased risk of asthma, cardiovascular disease, smoking alcohol, cancer, liver disease, stress, diet, infection, chronic diseases. Okay, so if this totally depends on your environment. For every disease, the biggest contributor is the environment. Environment also includes our own habits, our own diet, our own, whether we are smokers, whether we drink alcohol, whether we eat chips all the time. Everything adds up. That is all environmental. Okay, so genome and environment together, they determine the health thing. Sometimes genetics becomes very powerful. So for example, I know families where everyone will develop diabetes. Whether you eat sweet or not sweet, but you get those genes from your parents. So they are very prone to diabetes. So you have to be very good. People get obesity genes. Parents are obese, children are obese, right? But you can always fight it off. You are more prone to gain weight, but if you exercise, you will be thin. You have to work harder than other people who have slim genes, right? But so epigenetics, this goes without saying, epigenetics plays extremely important role, and exposome actually controls epigenetics. Okay, so the take home message is that Genome does not say that you will have diabetes. It will say you have high potential to get diabetes. You have high potential to get this disease. It is not giving you the final verdict. It is just telling you potential. Okay, an exposome says, okay, you live in this environment, I'll make sure you get this disease, or I'll make sure you don't get this disease. Okay, that is that. So it is the dynamic interplay between the two. Let's look at the case studies. You will really enjoy, because these are real cases and you will see how it goes. Okay, so this is that. African Americans traditionally are thought to have high blood pressure because they thought it is a racial trait these guys have in their genetics. However, average blood pressure from West Africa, from where most of the African Americans trace 80% of their genetic roots, to the West Indies and then to Chicago, you will see a stepwise increase in blood pressure. So in West Africa, they don't have hypertension. The closer they come to US and come to Chicago, blood pressure keeps shooting up. Okay, so this is not a genetic tendency, and it just happens people who live in that south side of Chicago. By the way, Michelle Obama, President Obama's wife, she always tells she's south from the south side. That is, you know, that is the poorest place, extremely high criminal thing. You don't want to go to south side because it has such criminal thing. So she always says a small girl from south side of Chicago went to become the First Lady of United States. And you know, First Lady of United States, you can say, well, her husband was the president, but you know what? She's extremely educated lady. She was a Harvard graduate. She became a Harvard student on her own, not her husband's thing. So she's extremely accomplished lady. So her genetics were fine. Her environment was as bad as it gets, right? And she rose to become what she is today, right? So your environment can be adverse, but you can rise and come out of that environment. You don't have to stay in that environment. You know, you work hard, you get out of that system, right? She always says, you know, White House was built by the slaves at that time from Africa, right? And she said, when she went to the White House, she said, every day I walk around and I said, my ancestors built this house, and today I have the privilege of living in this house. You know, so she was very mindful of that, and that is very motivating for people who are stuck in bad situations in south side of Chicago or similar areas, that they can get out and they can rise to the highest level, right? So even if the environment is bad, you can always get out of that environment. Nobody is stopping you from that, right? Case study 2, breast cancer outcomes. So African Americans, whenever they get breast cancer, it is always poor prognosis. So African American women have higher mortality from breast cancer compared to white women, despite similar incidence. Why? Because they don't have access to mammography. By the time breast cancer is diagnosed, it has truly advanced. White people, no symptom, you can pick it up, you can quickly treat it. They also get more aggressive breast type, like triple negative breast cancer. Socio-economic barriers to early treatment. Very good example of health disparity. Then diabetes in Native American communities. So Native American population have some of the highest rates of type 2 diabetes. Why? They have limited access to healthy food, right? So what happens is that, you know the story of Native Americans. So Native Americans are these are Native Indians also. Like, you know, when Columbus said red Indians, these are the people, right? So he was looking for India, he reached America, and they were very fair, so he called them red Indians, right? So these were the original people who were living there, and then people of European descent came, then they became the Friends, then they owned in the US, and these people were pushed to some small areas. So they are pretty isolated people, right? So those Native American peoples, they have limited access to healthy food. They have faced historical trauma. They were really marginalized, right? So systemic marginalization, inadequate access to preventive health care, which all other people have. So because of that, it has resulted in genetic predisposition towards diabetes. If you don't eat healthy food, diabetes is very easy to develop. Okay, it's a very easy thing. Okay, COVID-19 pandemic and racial ethnic minorities in US, Black, Hispanic, Latino, indigenous population faced disproportionate infection, hospitalization, and death rates. Not surprising, you can predict now, even during COVID. Higher likelihood of being essential workers, those people who really help. So, COVID time was so bad that people were not even allowed to see their loved ones if they were infected with COVID, right? They were taken. So, but there are people who are taking care of all of these patients and everything. So they were exposed, right? So these are the essential workers. Crowded housing, less access to testing, vaccination, pre-existing conditions like diabetes, hypertension, of course, higher fatality, okay? Physical environmental, higher exposure in low-income urban minority neighborhoods, more asthma, more cardiovascular diseases. I have heard that somebody was telling me that in Delhi, if you walk for even half a mile, you just get completely out of breath. But if you walk in a nice area, you can walk for miles and you don't get it because of the air pollution, right? So imagine you are living in that area day after day after day. It will help that. So housing condition so this is that Michigan-led crisis, contamination disproportionately affects marginalized communities, okay? Poor ventilation, mold in the house, infection, respiratory illness, okay? Now, this is food desert, lack of access affordable healthy food leads to obesity, diabetes. We were talking that some people are not educated enough to buy healthy food, not that they are poor to buy healthy food. So many times we see that you go to a supermarket and people have carts full of stuff, and if you look at their cart, we also buy stuff, but our thing is in the bottom because we are buying vegetables and everything, right? So that's their raw vegetables and fruits and things like that. But their cart is full up to that because there are no vegetables. They are all tin food. So overall their food is not much than ours, but ours is raw here, but these are all preserved, right, in boxes, in tin things, right? So they will save you time. You open the tin, you heat it up, this thing. But all of them have preservatives, and that is very bad for you. It is as bad as it gets to buy tin food and eat, right? So people, either they don't have time to cook food, either they don't understand what is healthy food. Oh, sorry. I thought somebody told us finally you can stop. So I was looking very hopefully. So yeah, but they are not educated enough to know that they should not eat this kind of food. And every time I see, I feel like, obviously I have to keep my mouth shut. Okay, but the thing is that they just don't know that they should not eat this kind of food, right? So it's a food desert, green spaces, lack of opportunities for physical activities. At least nowadays, when they build big apartment complexes, they have some facilities, physical facilities. But the thing is that those facilities are so dirty because people are sweating when they are running. So if you run in those facilities, you are probably likely to get more diseases, right? Because they don't clean it enough. So basically, there are many factors contributing to diseases. So healthcare infrastructure, fewer hospitals, clinics in rural or underserved area, access to preventive emergency care is very poor, okay? So neighborhood safety, unsafe areas limit outdoor activity. So in many times in India also, we don't go outside after this thing. We know if we walk around in this area, it is not safe, right? So leading to chronic disease risk, education, lower education, unstable jobs, less health literacy. This less health literacy really came out during COVID time because there was a large number of people who were really, really against vaccination. Like there was this real big fight, no vaccination, no vaccination, no vaccination. And we were craving vaccination, right? Like the fast, and then COVID came under control due to vaccination, right? Because otherwise it was just spreading and spreading and spreading, right? So, and it is not their fault. They just don't even know what is vaccination. Somebody was really saying it is a devil. You are putting a devil in your bloodstream, because somebody told them that, right? So chronic stress from systematic inequities. This is also a very sad thing. So, we cannot say that all Asians are bad, or all white people are bad, or all black people are bad. They're good or bad everywhere in everything, right? But these people will get labeled as bad all the time. So even if they are extremely good people, they are likely to be targeted by the police, right? If they see this person, okay, this person is this, obviously he has to be bad or she has to be bad, right? So, Serena Williams. We all know Serena Williams, the tennis player, right? She said, I feel so bad if my nephew goes out. He has 10 times higher chance of being caught by the police than any other person there, right? So that is a reality, right? And that gives stress to the person, constant stress about the safety of that person, right? So all of these contribute, right? Okay, environmental health disparity, air pollution and respiratory, this thing. See, in many African cities, residents are exposed to higher levels of air pollution from traffic, industrial emissions, and biomass fuel usage. Children face higher rate of asthma and respiratory infections. Okay, so environmental regulation, there is no environmental regulation. Lower access to healthcare for diagnosis treatment, right? Rural reliance on biomass fuel for daily living. So all of these things, right? Now we are saying greener environment, right? We should have cleaner this thing. We are saying, there are obviously huge amount of pollution all over the world, right? There is global heating going on, but everything just, this one, lack of Medicaid expansion, inadequate insurance coverage, barriers to care. People of color, people who are darker in color, people of color often are located near toxic waste sites or industrial pollution sites. When you go to US, right? So you will see like really beautiful houses, and you will see one-story houses and you can always see that the houses which are next to highways, which are next to the road, they are just really poor looking houses. The houses which are further away from highways, they are big and huge and beautiful houses. So just by location, I have never ever seen a beautiful house next to a road, like main road, because that area is very cheap if it is next to main road, because there is constant traffic. If it is next to the industry, higher crime rate, because the houses are cheap. So all those other people, they live in other parts of the thing. So living next to industry which is releasing a lot of waste in the air, those areas are a lot cheaper than if you go to places where it is much cleaner air. Okay. Chicago has stark neighborhood level disparities in environmental exposure. Black and Latino neighborhoods are disproportionately located near highways, industrial zones, and waste facilities. Okay. Asthma hospitalization rates for black children in Chicago are 5 to 6 times higher than white children. These are real numbers. Okay. Heat waves like 1995 Chicago heat wave caused disproportionate deaths in poor segregated neighborhoods lacking green space and conditioning. Okay. Then lung cancer in African American person, historical lower rates of EGFR testing. So this is what happens is that there is a story, a black woman went with lung cancer. They would not even do EGFR testing for her, and they treated her with chemotherapy because it was too much effort to do EGFR, and she had EGFR based lung cancer, breast cancer. So she died. because she was given chemotherapy. Okay, so they don't even test for which cancer it is, just give chemotherapy or radiation therapy. And okay, so take home message is that precision medicine without equity is incomplete. Okay, you can develop all the precision medicine, you are not even taking all the diverse population in your clinical trials. You have to know that, right? And keep in mind, the more population you will include, the more knowledge you are going to get. It is not about that person, it is all about your own knowledge in how disease is expressing in different ways in different human beings, right? So you can talk all about biomarkers, you can talk about precision medicine, but you have to have all the representation there. Then you have to make sure that all of them get equal access, right? I think this is the last one. Summary: the environment is not just physical, it includes social structure and policy dimensions, right? So this is a very important part of this one. So we hope in 2030, which is really next door now, okay, we will have more diversity and inclusion, we will have big data. So the best part is that, and this will come towards the very end of this course, right, when AI comes, AI shows the face here. But the thing is that there is so much data, but they are all segregated data, like people here have their own data, people here have their own data. So we have to combine all the data, right? And we cannot handle it as humans. So the AI can handle all the data pooled from all over the world, right? And then we have to integrate all of those data. So the last lecture will tell you that human mind cannot comprehend this amount of data at once, right? Because we cannot include every kind of thing. That's not even possible. So that's where AI can come as a collaborator in sieving through all this data and then really helping us. But we have to keep the final decision in our hand, not let AI make the decision. Okay, we can integrate, we can confirm, we can do that, and then we decide, okay, this is the precision medicine best suited for that. Okay, all right, this is self-explanatory, all the tests and everything. All right.